Welcome everyone to this new episode of MASH Masters, MASH Guidelines Update. What do they mean for practice? I'm your moderator, Dr. Naim Alkhouri, the Chief Medical Officer at Summit Clinical Research, and I am delighted to be joined today by Professor Mary Rinella, who's Professor of Medicine, Director of the Metabolic and Fatty Liver Disease Program at the University of Chicago. Welcome, Dr. Rinella, and thank you for joining me.
Thank you. It's a pleasure to be here.
All right, let's dive into the guidelines. So you are the first author of the AASLD guidance update that was published in 2023. Give us your take and how did you guys come up with this screening algorithm?
Yeah, thank you. So I think what the most important thing about this particular guidance compared to the one that just preceded it is that we actually provided specific guidance regarding high-risk populations and who to screen. I think that was a notable thing that was missing from the last time around, because there are certain populations that are very high risk. So patients with diabetes, those with medically complicated obesity, those with family history, first-degree relative with cirrhosis, et cetera. So that was sort of the basic main change. The other is that we gave a more prescriptive guidance with respect to sequential screening using non-invasive tests. And our intention was to make this applicable not just to hepatology, but also to primary care. And so you can see in this algorithm that we start with FIB4. And the primary strength of FIB4 is in its negative predictive value in a general population. And what we were trying to do is highlight those patients who really didn't need to be referred for specialty care. And you can see here that those that have a FIB4 less than 1.3 were sent back or remain in primary care. Those that are above that then undergo secondary testing with VCTE most commonly, and then ELF in areas where there's no VCTE available. And then based on those of intermediate and high risk could then be considered for further GI hepatology care. And then, Naim, I don't know if you want to go through what we might do in GI hepatology care with those patients that are referred to us that are high risk.
Yeah, I mean, what I like about this guidance update is that you provide specifics about what can be done in a hepatology clinic, including MR elastography. You mentioned other technologies like corrected T1, and then I want to highlight that at the end, if you have discordant NITs and you are not sure, then a biopsy is still a good option. I think by implementing this algorithm, only about 5% of patients will probably need a biopsy when it's all said and done. But again, I want to emphasize that, if biopsy is the only way to have confidence in staging the disease, then be it, because we owe it to our patients to know exactly what stage they're in, because we have effective pharmacologic treatments now and, therapeutic options, clinical trials. So thank you for this overview. I think by implementing this FIB4 with sequential testing, only about 8 to 10% of patients will need to be referred to hepatology. So I think it will save us as subspecialists a lot of time, and also it will help the primary care physicians take ownership of risk stratifying these patients. The other good thing is that now we are seeing, MASLD being mentioned in other societies' guidelines. The ADA recently also had, an update on their guidance, and they have a MASH diagnostic algorithm. Any, new insights about the ADA algorithm? I'm glad to see that it's kind of similar to the AASLD.
It is, and it's also similar to the ACE guideline that preceded it in 2022. I think what's important is that there's consistency with what's being recommended. Broadly speaking, FIB4 being the first cut point, followed by secondary testing with liver stiffness, specifically in this algorithm. And this is primarily going to be read by diabetologists or endocrinologists and primary care. And so again, the most important thing for them is to identify those who are at high risk for disease progression. I think that's something that's been a notable problem. And Naim, you briefly touched on it, but we do see way too many patients who are referred only because they've developed hepatic decompensation or overt evidence of liver disease. And that's a big problem because we can prevent it. We have treatment, we have FDA approved treatments now that we hope will slow that progression and reduce the risk of liver related outcomes down the road. So again, super important to identify those high risk patients, particularly because people are asymptomatic. Often their liver chemistries can be either normal or just mildly abnormal. And I think the primary care and endocrinology falsely equate mild abnormality with not being too sick. And actually, as liver disease progresses, your ALT and AST can actually go down. So I think that's really an important thing. So again, this is great because it reinforces referral of patients of high risk. And I think that's what we need, exactly what we need.
Yeah, no, very important points. And you mentioned other guidelines, and I agree. Overall, I think there's consensus, but there are some nuances. So if you want to give us your take on maybe some minor differences in the guidelines.
Yeah, so I think for the most part, they are harmonized. I'll say that some of the differences are going to come from, for example, as noted here on the left with ACE, the ACE AASLD combined guideline that was published in 2022. Of course, we did not have approval of resmetirom or semaglutide, which is the more recent FDA approval. So it couldn't really speak to that per se. So that would be the reason, not because they disagree, but rather because the timing was not appropriate for that to be recommended. The perspective from ACE and ADA is going to be slightly different than it might be for AASLD because it's meant for a slightly different audience. The one thing that you do see throughout is the use of GLP-1 receptor agonists or dual GLP-GIP agonists. And that's because they've been approved for the treatment of obesity and diabetes and depending on the agent, heart failure or obstructive sleep apnea. And so patients that have those cardiometabolic risks will benefit from those irrespective of liver disease. So those are recommended just really to treat those underlying metabolic diseases. And that's true across the board. The more recent ones are going to incorporate more data from the use of those drugs in the context of liver disease specifically. But yeah, that's I think the main takeaway differences.
Yeah, and I like that all the guidelines tell us what diabetes medicines are beneficial for patients with MASLD and MASH, and it's good to see that there's pioglitazone, SGLT2 inhibitors, in addition to GLP-1 receptor agonist. And as you said, now we have guidance how to select patients for resmetirom. Semaglutide recently also received the FDA approval for the MASH indication, and for the most part, this has been done with non-invasive tests, mainly with VCTE and MRE. So it's good that we can provide guidance now to clinicians how to select patients. We also have recommendations how to follow them and assess for response to treatment. So moving on to other societies also, now the European Association for the Study of Obesity has also some specific recommendations for the management of MASLD and MASH. If we can go to the next slide, I think it projects better. But what they have here is, treatment of what they call sick fat diseases, and they actually include MASLD, which is good. So what is your take, Dr. Rinella, on this new guidance from the European Association for the Study of Obesity?
Thank you. Yeah, so I would say from a 10,000-foot view, I am thrilled that other groups of providers, such as those interested in obesity and cardiometabolic disease in general, are including MASLD. This was a very clear omission for many, many years. So this is great to see it in here as a disease that is worsened and even caused by adipose tissue dysfunction, because that is, I think, the main driver of the disease. So that's great. I will say the one thing that I fear might be slightly misleading about this is that while yes, you will see improvement in steatohepatitis, most likely when you treat with these drugs, it is not, first of all, not in all patients. And secondly, when we make recommendations like this, I think we need to be careful to provide evidence-based recommendations that are supported by the phase 3 trials ideally, and then even more so if there's FDA approval. So in this particular context, semaglutide is FDA approved now. There's phase 3 data demonstrating improvement or MASH resolution and fibrosis improvement. However, I think something that cannot be overlooked is that we have to risk stratify these patients. Not everybody responds to treatment, and particularly with fibrosis, the data are not overwhelming with respect to magnitude of improvement. And so I think we can't forget about patients who have adiposity-based disease, who have MASH, who are on a GLP, and then we just forget about them. I think that is not a message that we want to perpetuate. I still think they have to be risk-stratified. It's really important in my mind.
Yeah, I couldn't agree more. I mean, GLP-1 receptor agonists have been transformational medications for treating multiple comorbidities. However, when I look at my patients with type 2 diabetes coming to the steatotic liver disease clinic, about 30-35% come to me on a stable dose GLP-1, and yet they still have evidence of MASH with F2, F3 fibrosis. So clearly, potentially adding resmetirom or maybe some future therapeutics will be a good idea. And then we have about 20-30% that are off the GLP-1 within the first year of treatment because of tolerability issues. And then we have patients that lose some weight, but it's really 5 pounds, 6 pounds, and we do believe that most of the benefits from GLP-1 receptor agonists are mediated by weight loss. So if the weight loss is not what you would expect, you also need to keep that in mind. So I think the message is that if you have someone on a GLP-1, you can't say that the liver is going to be okay. You need to assess, monitor. If you see disease progression, then you need to think about maybe potentially combination therapy.
Actually, let me add one comment to that too, Naim. So 100%, obviously, I agree with what you're saying, and that's specifically why these need to be called out in all of these guidelines, in the Obesity Society guidelines and other, because there is no obvious abnormality on liver chemistries that heralds the presence of advanced disease. We have to overtly recommend that screening and assessment. And if you're on a GLP, if you haven't had an adequate response or you still have fibrosis, that person needs secondary treatment and with another agent or in a clinical trial, for example.
Absolutely, couldn't agree more. Moving on also to a new guideline document. This is the AACE 2025 update. And what I like about this is they're talking about complications of ABCD, which is adiposity-based chronic diseases. As you mentioned earlier, I'm just happy to see MASH and the liver mentioned. This is very good. But anything you would like to highlight from these new guidelines?
No, I agree. I think it's great to see it mentioned again. That it's a little bit curious that again, if we of course look at it from a MASH-centric lens, and I look at that, and the first thing I see is, okay, well, there's no phase 3 data in tirzepatide. I think it's a great drug. It's likely to be a very effective drug, but phase 3 is barely just starting. Semaglutide, we do have phase 3, and it's FDA approved. So that really, I think, if you look at MASH and you want to treat that, it really should be kind of prioritized. And again, the same issue with this one, risk stratification is critical. Failure of therapy, inadequate response, intolerance of GLP should then lead you to the use of resmetirom. And then depending on how the response is with that, potentially a clinical trial or other, but hepatology referral, certainly.
Yeah, and I think, again, the key message here is that you might be starting the GLP-1 or the dual agonist to treat diabetes, or maybe, you're looking at the CKD aspect of it, but to make sure that you are doing a liver assessment. and not to assume that because the patient is on a GLP-1 that the liver is responding in the same way. I've had patients that were started on a GLP-1 with great control of type 2 diabetes, yet liver fibrosis did not show the same benefit. Well, thank you so much for providing all these great insights. And for the audience, if you want to learn more, please visit our MASH Clinical Advances page, and you can scan this QR code. But any last words of wisdom, Dr. Rinella?
No, just look for it. Look for advanced disease, screen for it, and follow your patients up as needed. We're happy to answer any further questions here, or you can email me too. Actually, I'm happy to answer emails. So.
Thank you so much. It was lovely having you, and thank you for the audience for joining us today.
Thanks, Naim.